Thank you. Well, I must thank Professor Alderson for a very special invitation in discussing what in 1962 was a very difficult problem, I guess. Now this is forward. Okay. So Professor Alderson sent me, as a good editor, a paper to review with a 1962 mind on what was available at that time for the problem which was proposed. So Mr. Large presented us a paper on the problem of short esophagus and esophagitis. I think he favored us by giving a clear definition of what in the early 1960s was a short esophagus. The esophagus which at operation is not long enough to allow the esophageal gastric junction to lie below the diaphragm, even by transplanting the esophageal hiatus forward. So that's so right there. I started reading. I can tell you because this is not the usual approach that we have in these days, and it's very interesting that after defining what a short esophagus was, a definition I think that is needed today in the discussion about what is short esophagus, what is an anti-reflux repair without any tension. Professor Large came up with two etiologies for the short esophagus: the acquired one, which was seen with hiatal hernias, and the other one was a congenital one, presented as the shortened esophagus without any type of hernia present. Of course, with today's knowledge about the behavior of the lower esophageal sphincter, I think this illustration in the decade that followed the description by Mr. Allison and Mr. Barrett of what was a metaplastic esophagus with a Barrett's esophagus, I think it's fascinating to read that in his presentation. So Mr. Large wanted to discuss the use of distal gastrectomy, vagotomy, and ROUX-Y gastrojejunostomy for a shortened esophagus with severe and intractable esophagitis. And his rationale was the acid pepsin regurgitation mixed with the alkaline intestinal juice that must be stopped, and resection of the esophagus might be required later. So he went on to present 4 patients, the history of 4 patients. The first one is a 48-year-old patient with a 2-year history of dysphagia, radiologically presented with esophagitis, with visible esophageal ulcers and esophageal shortening. And at endoscopy, this was correlated with hemorrhagic and an edematous lower esophagus. The patient underwent a 40% gastrectomy with an 18-inch ROUX-Y. No hiatal hernia could be documented. Following the operation, there was an early delayed emptying, but the patient became immediately asymptomatic, and subsequently he documented a complete healing of the pathology in the esophagus. The second one was also a 47-year-old heavy drinker with dysphagia for the last year. Radiologically, he had a 4-centimeter stricture with a stomach in the chest. Radiologically, a stomach in the chest. He had esophageal ulcers also visible, and endoscopically, there was a stricture, there was inflammation, but the dilatation was still possible. At operation, no hernia was documented, and he said this is a congenital type of shortened esophagus. So he underwent a 50% gastrectomy, a vagotomy, and ROUX-Y, and 2 months later he had to undergo a distal esophagectomy because of restructuring. But after the operation, no recurrent esophagitis was documented endoscopically. The third patient was a 69-year-old lady who had prolonged nasogastric suction after a hysterectomy. She presented with a long stricture in the lower third of the esophagus. Endoscopically, this corresponded to severe esophagitis, a stenosis without any evidence of malignancy, but a significant inflammatory mass around the esophagus. She's the only one of the 4 patients who had a small hiatal hernia and a shortened esophagus. And Mr. Large proceeded with an esophagectomy with proximal gastrectomy. And 3 weeks later, he offered the patient a 50% gastrectomy with a ROUX-Y diversion. There was a normal healing, again, without any evidence of esophagitis on follow-up. And the last patient, dysphagia for 3 years, 67-year-old, obstructive lesion of the lower esophagus with esophagitis, stenosis, a shortened esophagus with a clear obstruction endoscopically and a fixed lower esophagus. At operation, as 2 other patients, no hiatal hernia. The patient undergoes a distal esophagectomy and a proximal gastrectomy, and a 40% gastrectomy in ROUX-Y was offered 2 weeks later, and the follow-up showed no dysphagia and a normal esophagus. So these are 4 aggressive operations to treat a shortened esophagus, and the reason for the 1960 treatment of the shortened esophagus was for stubborn cases of esophagitis, particularly in patients with a shortened esophagus. At that time, medical treatment, and you can understand that with no anti-H2 medication, no PPIs, medical treatment are likely to be disappointing. Medical treatment at that time was strictly ulcer surgery medical management. Surgical treatment, too, has left much to be desired, with recurrence and progression of the inflammatory process in the lower esophagus likely to occur. So that was the hypothesis of Mr. Large when he presented his four cases. So what I've tried to go back and extract only the literature related to reflux esophagitis, stricture, and a shortened esophagus, what you did for that problem in the early 1960s. This is the early period of 1960 was early middle period, I would say, of anatomic repair for a hiatal hernia. Harrington had described those in 1938. Professor Allison had described his anatomic repair in 1951. Lorta Jacob in Paris, 1957, and Sweet in Boston in 1962. And all those, after Mr. Allison's presentation in 1973, if I remember well, were left aside, and nobody talked about anatomic repair to try to stop the damage being done to the esophagus. And it's very interesting that the early reports of the initial anti-reflux surgery that were discussed over the following 30 years, that of Hill, that of Nissen, and that of Belsey, were presented and published in 1961. So exactly at that period, we were starting to talk about anti-reflux correction instead of anatomic correction. There were plastic repairs that were proposed in that time in order to bring down the esophagogastric junction under the diaphragm. You have seen that 3 out of the 4 cases were unreducible GE junction under the diaphragm, and 3 of the presented patients had radiologically a large hiatal hernia described in the chest, while there was no hiatal hernia surgically. And that is very interesting in the perspective that maybe 5 or 8 years before, both Mr. Allison and Mr. Barrett had presented their initial cases of Barrett's esophagus. But at that time, Merendino had proposed to change the position of the hiatus on the diaphragm, and Effler in 1951 proposed the same approach, but this this was never emphasized extensively. The plastic repairs at the esophagogastric junction was proposed in 1957 and 1961 by Collis. He proposed the elongation gastroplasty, as we call it today. And a little further on, Thal presented with the cardioplasty, with the Thal repair, with a total fundoplication left in the chest. And this was followed again by 25 years of argumentation on the value of these plastic repairs. And today we still have as a significant contribution the Collis repair with a partial or a total fundoplication, which with much more information that was available to Mr. Large in 1962. I guess the most popular approach for the strictured esophagus in the early 1960s was resection. And Merendino had proposed the jejunal interposition in 1958, and it was used extensively in America. Mr. Allison initially proposed a complete gastric bypass, and that was in 1953, a complete gastric bypass to avoid both the acid and the bile mix in the reflux, in the esophageal reflux. But subsequently, he shifted his opinion to using an esophago-jejunal gastrostomy, the equivalent of a Merendino operation, and he published that in 1965. Mr. Belsey was the champion of colon interposition, and his large experience with mostly the short colon interposition was proposed as a solution for exactly the type of problems we've seen here. And Sweet in Boston used and proposed mostly the distal resection with a gastric interposition, a gastric transposition, I should say. And this was also used by Ellis, who subsequently worked at the Mayo Clinic. Indirect resectional therapy, a vagotomy, an antrectomy, a ROUX-Y, was alluded to by Wangenstein, who documented well the severe damage that resulted from mixed type of reflux, a mix of acid, a mix of acid enzymes and bile in the esophagus, refluxing in the esophagus, and that's been well documented in the period that followed, where this mixed reflux was shown to be much more damageable to the esophagus than single refluxates. And it brought Wells in 1955 to propose actually to treat refluxing patients by antrectomy and ROUX-Y diversion. But you see that Mr. Large with Dr. Holt, Mr. Large by himself, Mr. Large with Mr. Weaver was certainly enthusiastic about this approach, and I suspect that this was a natural follow-up to treating gastric and duodenal ulcer surgery. Still, Dr. Payne at the Mayo Clinic, 10 years later, adopted this approach to treat severe and difficult to treat reflux disease. So vagotomy and antrectomy in the ROUX-Y, what are the advantages? Today, if you use this operation, and I think it's an excellent operation, there's no discussion. The advantages is that you can measure the outcome for symptoms, you can measure the outcome for acid and bile exposure, you can measure the outcome for mucosal damage, for function, both in the esophagus and the stomach, for emptying and for function. And there is no discussion that a ROUX-Y is a good operation, an antrectomy and a ROUX-Y. These disadvantages that we could mention reading the paper are mostly that the known outcome stem from gastric surgery. There are selective reports on treating esophageal disease, reflux disease, end-stage motor disorders, and different situation focused on the esophagus. One of the argument being proposed that the diseased esophagus is left in place if you treat a Barrett's esophagus, but also that the stomach has to be sacrificed as a reconstruction organ if it ever came to that situation. And I would add to this that a Roux-Y reconstruction, despite not knowing exactly the ideal length to be used for a Roux-Y, excludes the access to the duodenum itself. Vagotomy, ANTRECTOMY, and Roux-Y is not a benign operation. Its morbidity is well documented. Incomplete vagotomy or a retained antrum lead to stomal ulcerations, stomal stenosis. The gastric remnant may show delayed emptying, bezoar formation. The gastrojejunal loop, the Roux loop, shows usually for a few months motor dysfunction. It's exposed to kinking, and it may show stasis as well. And the jejunal loop from the duodenum has shown some chyle mixing asynchrony with occasionally an afferent loop syndrome. So after reading this paper a couple of times, my recommendation to the editor of BJS would be that the paper contains a hypothesis and goals that are clear. The results are impressive, actually, for the type of problem that has been presented. It is reported with objective documentation of results, endoscopic documentation of control damage, but one conclusion could be questioned and could be sent back to the author. The operation, in one of his conclusions, he says the operation should be recommended before stenosis of the esophagus has occurred so that the relatively simple procedure of distal gastric resection, vagotomy, and Roux-Y reconstruction can be performed with its low morbidity and mortality. And I think I would suggest some modification on that conclusion. Thank you for your attention.